Welcome to the fifth section of your course, focusing on trauma and shock management. In this module, you will learn the mechanics of physical injury, how to control severe bleeding, and the life-saving interventions required for shock. This topic is incredibly important because trauma calls are fast-paced and require rapid, aggressive decision-making to save patients who are quickly bleeding out. I am excited to guide you through these high-intensity concepts, as mastering these skills will make you a vital asset on any rescue scene. Let us get ready to explore the critical rules of trauma care and sharpen your ability to perform under pressure, to fully lock in these high-stress protocols before moving forward. I highly recommend obtaining our practice tests or downloading the offline app, which serve as excellent practical tools for reinforcing your real-time decision-making skills. To effectively treat a trauma patient, you must first understand the kinematics of trauma, which is the study of how energy transfers through the human body during a collision. By closely examining the mechanism of injury, such as the speed of a car crash or the height of a fall, you can predict the types of hidden internal injuries your patient might have sustained. The NREMT exam will constantly ask you to use these clues, expecting you to maintain a high index of suspicion for severe injuries, even if the patient looks perfectly fine on the outside. Trauma is generally divided into two main categories, which are blunt trauma and penetrating trauma. Blunt trauma occurs when a forceful impact strikes the body without breaking the skin, such as a baseball bat to the ribs or a steering wheel to the chest, which often causes massive internal bleeding. Penetrating trauma involves an object piercing the skin and entering the body, like a knife or a bullet, creating a direct pathway for severe external hemorrhage and infection. Knowing the difference helps you decide whether to focus heavily on finding hidden internal damage or managing obvious external wounds. Recognizing the different types of external bleeding is your first step in wound management. And arterial bleeding is the most dangerous. Arterial bleeding is bright red and spurts aggressively in time with the heartbeat, meaning a patient can bleed to death in just a few minutes if you do not act quickly. Venous bleeding is dark red and flows steadily, while capillary bleeding is a slow, minor ooze typically seen with simple scrapes. The exam will expect you to prioritize bleeding control over everything else, treating massive arterial hemorrhage before you even open the airway. The very first intervention for any significant bleeding is applying direct, forceful pressure straight down onto the wound using a sterile dressing. You must use your gloved hand to push firmly against the injury, maintaining that pressure without letting up to peek at the wound, as doing so destroys the blood clots that are trying to form. If blood soaks completely through your first dressing, you should never remove it, but instead place a second dressing directly on top and press even harder. This fundamental skill is heavily tested because it is the most common and effective way to stop hemorrhage in the field. If direct pressure fails to stop severe bleeding on an arm or a leg, you must immediately apply a commercial tourniquet. A tourniquet should be placed high and tight on the extremity, generally 2 to 3 inches above the bleeding site, but never directly over a joint. You will tighten the device until the bright red bleeding completely stops, and you can no longer feel a pulse below the injury. A classic exam tip is to clearly write the exact time of application on the tourniquet or the forehead of the patient, as the hospital needs to know exactly how long the limb has been without blood flow. Beyond severe hemorrhage, you will manage a variety of soft tissue injuries, including abrasions, lacerations, avulsions, and amputations. An avulsion occurs when a flap of skin or tissue is torn loose or pulled completely off, requiring you to gently fold the flap back into its normal position before bandaging. For complete amputations, you must wrap the severed body part in a sterile dressing. Place it in a watertight plastic bag, and keep it cool by placing that bag inside another container filled with ice water. You must never place an amputated part directly on ice, as this will freeze the tissue and destroy any chance of surgical reattachment. Burns are a unique type of soft tissue injury evaluated by their depth and the total body surface area they cover. Superficial burns involve only the top layer of skin causing redness. Partial thickness burns cause intense pain and blistering, and full thickness burns destroy all skin layers, often leaving the area charred, white, and leathery without any pain. To calculate the size of a burn, you will use the rule of nines, which assigns percentages to different body parts, such as 9% for the entire head and 18% for the entire front of the torso. You must treat severe burns by stopping the burning process, removing smoldering clothing, and covering the area with dry, sterile dressings to prevent infection and heat loss. To test your precision with these mathematical burn calculations, pulling up a quick review on our practice tests or checking the offline app is an excellent way to see how these tricky scenarios appear on the actual exam. Musculoskeletal trauma involves injuries to the bones, joints, and muscles, presenting as fractures, dislocations, sprains, or strains. A fracture is a broken bone, which can be closed with the skin intact, or open where the broken bone ends pierce through the skin, introducing a massive risk for infection. A dislocation occurs when a joint is forced out of its normal anatomical position, often locking the limb in a strange, painful angle. While these injuries are incredibly painful and visually shocking, the exam will remind you that they are rarely life-threatening unless they involve massive blood loss from the pelvis or femur. The primary treatment for musculoskeletal injuries is splinting, which immobilize the broken bone to prevent further tissue, nerve, and blood vessel damage during transport. The golden rule of splinting is that you must always immobilize the joint above and the joint below the injury site, before and after applying any splint. You must check the pulse, motor function, and sensation, commonly referred to as PMS, in the extremity. If a patient has a strong pulse before you apply a splint, but the pulse disappears after you secure it, you have tied it too tightly and must loosen it immediately. One highly tested, specialized splint is the traction splint, which is designed exclusively for isolated mid-shaft femur fractures. The femur is the largest bone in the body, and when it breaks, the powerful thigh muscles spasm and pull the broken bone ends past each other, causing excruciating pain and massive internal bleeding. A traction splint uses mechanical pulleys to gently pull the leg back out to its normal length, relieving the muscle spasm and reducing the hemorrhage. You must remember that a traction splint cannot be used if the patient has additional injuries to the hip, knee, lower leg, or ankle on that same side. Head injuries are terrifying because the brain is trapped inside a rigid skull with absolutely no room to expand if it begins to bleed or swell. A concussion is a mild traumatic brain injury that causes a temporary loss of brain function, often resulting in confusion or amnesia of the event. However, epidural and subdural hematomas involve actual bleeding inside the skull, which rapidly builds pressure that squishes the brain tissue downward toward the spinal cord. Recognizing and increasing intracranial pressure is vital, as it requires you to hyperventilate the patient slightly and rush them to a trauma center. To identify severe intracranial pressure on the NREMT exam, you must memorize a specific pattern of vital signs known as Cushing triad. While most patients in shock have a fast heart rate and low blood pressure, a patient with a severe head injury will present with the exact opposite. Cushing triad consists of a very high blood pressure, a dangerously slow heart rate, and an irregular breathing pattern. If a scenario describes a patient who was struck in the head and now has a blood pressure of 200/100 with a heart rate of 40, you must recognize this as a critical brain injury. Suspected spinal injuries require meticulous care, as any careless movement could sever the spinal cord and leave the patient permanently paralyzed. If the mechanism of injury suggests a spinal fracture, your first action must be holding manual, inline stabilization of the head and neck, preventing the patient from moving. You will then apply a rigid cervical collar to maintain this neutral position, ensuring it fits perfectly without obstructing the airway. You must maintain your manual grip on the head until the patient is completely secured to a long backboard or firmly strapped onto your stretcher. Chest trauma can drastically compromise breathing, especially in the case of a flail chest, which occurs when 3 or more adjacent ribs are broken in 2 or more places. This creates a floating segment of the rib cage that moves in the exact opposite direction of the rest of the chest during breathing, a dangerous condition known as paradoxical motion. This prevents the patient from pulling in a normal breath and severely bruises the underlying lung tissue. Your treatment involves supporting the patient breathing with a bag valve mask, as the positive pressure helps push the flail segment outward and expands the lungs. Another critical chest injury is a sucking chest wound, which happens when a knife or bullet punctures the chest wall, allowing air to rush into the chest cavity every time the patient takes a breath. This trapped air begins to collapse the lung, leading to a deadly condition called a tension pneumothorax. You must immediately cover the hole with an occlusive dressing, which is a special plastic or foil bandage that blocks air from entering but allows trapped air to escape out the sides. Exam questions will constantly test your reflex to slap a gloved hand over this type of wound the second you see it, before you even reach for a dressing. Abdominal trauma can result in a gruesome injury called an evisceration, where a large laceration allows the internal organs, typically the intestines, to spill out of the body. You must never attempt to push the organs back inside the abdominal cavity, as this will cause massive infection and tissue damage. Instead, you will cover the exposed organs with a large, Sterile dressing soaked in sterile saline. And then cover that moist dressing with an occlusive layer to trap the body heat. The NREMT exam frequently tests this exact bandaging sequence to ensure you know how to protect these vital organs from drying out. All severe trauma eventually leads to shock, which is medically known as hypoperfusion, a state where the organs are not receiving enough oxygenated blood to survive. Shock progresses through stages, beginning with compensated shock, where the body panics and tries to save itself by increasing the heart rate and constricting blood vessels to maintain blood pressure. If the bleeding continues, the patient enters decompensated shock, marked by a sudden, dangerous drop in blood pressure, indicating that the body has completely run out of energy and the mechanisms are failing. You must catch shock in the compensated stage, because once the blood pressure drops, the patient is incredibly close to death. There are several types of shock, but hypovolemic shock is the most common in trauma, caused by massive blood or fluid loss. Cardiogenic shock happens when the heart is severely damaged and cannot pump, while neurogenic shock occurs when a spinal cord injury paralyzes the blood vessels, causing them to suddenly dilate. Regardless of the type of shock, the basic field treatment remains exactly the same for an EMT. You must aggressively manage the airway, apply high-flow oxygen, keep the patient perfectly warm with thermal blankets, and initiate immediate, rapid transport to the hospital. I want to congratulate you for completing this intense and comprehensive section on trauma and shock management. I encourage you to complete the attached practice test for this module, as visualizing these high-stress scenarios through practice questions is the best way to improve retention and exam readiness. You will find that the practice test is included with this lesson, or you can access our offline app anytime, anywhere, to help you confidently master bleeding control, splinting, and shock recognition. Embracing these interactive practice tests and app resources ensures an active learning approach, making you a much stronger provider on the streets. Let us naturally transition to our final section, where we will explore the unique challenges of special populations and obstetrics.